In this chapter, we are going to talk about the different diseases related to gastrointestinal system. So, as an example, in this chapter contained gastroesophageal varices, gastroesophageal reflux or GERD, peptic ulcer, most common is right, pancreatitis, cholecystitis, hepatitis, and irritable bowel disease, intestinal obstruction, or ulcerative colitis, and Crohn disease. There are so many diseases related with gastrointestinal system. Sometimes it make us confusion. This is the reason I want to review the gastrointestinal disorder today. The first disease discussed here, it is cirrhosis, right? Cirrhosis. So cirrhosis are the chronic and progressive disease. So the chronic means if the disease long time persists or more than 6 months or repeatedly attacked, and progressive. So if the cirrhosis is not treated well or maltreatment, cirrhosis leads to the liver failure or hepatocellular carcinoma. So if a patient diagnosed by hepatitis, right, hepatitis A, B, C, this hepatitis, if you not treated, it leads to cirrhosis. If cirrhosis is not treated, it leads to hepatocellular carcinoma. So the repeated destruction of hepatic cell. So this is the normal liver. So liver is the largest gland in the body. Liver is the most important for metabolism, where the food particles break down and produce energy as a ATP. So if my liver does not work, so metabolism will be impaired. If metabolism impaired, body does not produce enough ATP or does not produce enzyme. An enzyme is very important for chemical reaction. It is called biochemical reaction because this chemical reaction occur inside the living tissue, living cell. So it is called biochemical reaction. So in this picture, you can see the healthy liver, smooth, red color, but if the liver causes injured by hepatitis, not treated, cirrhosis developed. In the picture, liver is look like nodule, non-functioning hepatic cell. Liver with cirrhosis. Cirrhosis has many causes and is due to the chronic damage and injury to the liver cell. The liver cells are called hepatocytes. The most common are chronic hepatitis C, or if the patient alcoholism, too much drink alcohol, or non-alcoholic fatty liver, and also non-alcoholic steatohepatitis, right? So basically here they said the hepatitis, particularly hepatitis C. Hepatitis A basically transmitted fecal-oral route. Hepatitis B transmitted blood or blood product. Hepatitis C also transmitted through blood or blood product or sexual infection, right? So hepatitis C or any hepatitis most commonly occur or risk factor IV drug user, right? You'd see some people do tattoo in their body. This time can also possible to transmit the hepatitis. Unprotected sex or travel to underdeveloped countries or crowded living environment chance to spread out the hepatitis. If anybody have the hepatitis at the beginning, they have a flu-like symptom, fever, jaundice, or dark color urine and clay color stool. So like the picture number 2, if a patient have the cirrhosis and if you examine the liver enzyme, definitely it should be altered like ALT, AST, or bilirubin level will be altered. So here showing some of the important risk factor or causes of the liver cirrhosis or liver disease like chronic alcoholism, hepatitis, right, if untreated or maltreated. Autoimmune hepatitis can lead to cirrhosis or primary biliary cirrhosis. So primary biliary means the biliary system involvement like left or right hepatic artery, common hepatic artery, if any cirrhotic change up there also lead to cirrhosis. In this picture, you can see the complication of cirrhosis. For NCLEX board, we are going to give a very basic focus. So in this picture, you can see the distended abdomen because the liver does not function well and fluid is accumulate in the abdomen, and this is called ascites, right? What are the other complications? Like portal hypertension developed. What it is? The persistent increase in pressure in portal vein. Portal vein means hepatic vein or the vein inside the liver, portal vein, that develop as a result of obstruction of the flow. In the other picture, we will going to, or I will going to show you the different branches of the portal hepatic system. So accumulate of the fluid inside the peritoneal cavity that result from venous congestion of the hepatic capillaries. And capillary and congestion lead to the plasma leaking directly from liver surface and portal vein. So if we make it easy, then I want to tell you the liver cell does not work, portal circulation does not work well, and fluid is accumulate, blood is accumulate and develop the ascites. Another problem is called bleeding esophageal varices. Definitely we have another PowerPoint where we talk about the esophageal varices, and I will explain more. But here I want to tell you, esophageal varices means the swelling or fragile blood vessel in the esophagus that can hemorrhage, and definitely hemorrhage are the life-threatening, right? And portal hypertension is a risk factor to develop esophageal varices. So what is portal hypertension, my friend? In the top, portal hypertension means increase the blood pressure in the vein from intestine to the liver due to cirrhosis or due to hepatitis. If the patient have a esophageal varices, how you have to understand or diagnose, or what are the signs and symptoms, or what are the data? Usually elevated the liver enzyme like AST, ALT, and also with bleeding. If the patient has hemorrhoids or bleeding, it leads to hypotension. It leads to tachycardia and decrease hemoglobin and hematocrit. Another problem developed is called esophageal coagulation defect. Why? Because liver is the most important organ to synthesize the clotting factor. If liver does not work, clotting factor does not synthesis. Because of deficiency or lack of clotting factor, blood does not clot. So bleeding is most common. Coagulation defect. So decrease the synthesis of bile fat in the liver, prevent absorption of fat soluble vitamin. Without vitamin K and clotting factor, there's some clotting factors here, right? Like factor number 2, 8, 9, 10. They does not formation and lead to the coagulation defect. Other complication like patient develop jaundice, they develop portal systemic encephalopathy or hepatorenal syndrome. Just give a little bit look what it is and what they are. So jaundice means yellow discoloration, right? Because of increase the bilirubin. So jaundice occur because the liver is unable to metabolize the bilirubin. So bilirubin going up, right? And also edema, developed fibrosis or scar in the liver, hepatic bile duct, and they does not help to drain the bilirubin. And definitely, if does not drain, does not metabolize, increase the bilirubin level, which causes the jaundice. Portal systemic encephalopathy, right? So end stage hepatic failure characterized by altered level of consciousness, neurological symptom, impaired thinking, neuromuscular disturbance, and caused by failure of diseased liver to detoxify neurotoxic agents such as ammonia. So liver is the important organ to detoxify the ammonia or eliminate the ammonia. Ammonia is produced because of metabolism. If ammonia does not detoxify or does not exit or eliminate from the body, ammonia accumulates in your blood, and when ammonia is too much and they enter to the nervous system in the brain and causes the impaired the brain function, and patient will be confused, unconscious, or it's called altered level of confusion, right? And also other neurological symptoms as well. So all of these can develop, and we said portal systemic encephalopathies. Hepatorenal syndrome, what it is. So liver get involved in the renal, and it's called hepatorenal syndrome. So progressive renal failure associated with hepatic failure. So if your progressive renal failure associated with hepatic, so liver has to detoxify the materials. If liver does not work well, the materials try to passing through the kidney, and kidney is overload, right? Characterized by sudden decrease in urine output, elevate blood urea nitrogen, and creatinine level. Decreased urine sodium excretion and increased urine osmolarity. So in this table collected from Sender book, so there's some data or sign and symptom of cirrhosis liver. Like, what are the dermatological change? What are the endocrinological change? What immunological change? What renal system change? Right? And what are the fluid and electrolyte disturbance? What cardiovascular findings? And what are the hematological? So as an example, I'm going with a few one, like dermatology. Patient developed jaundice, plumbar erythema, or itching. Why itching? Because accumulate of the bilirubin under the skin, or sometimes patient develops spider angioma, especially chest or thorax, right? Endocrine, like increase the aldosterone, increase antidiuretic hormone, and also patient develop the gynecomastia in case of man. Immune system, increase the susceptibility of infection, easily catch up. Hepatorenal syndrome, what we discussed a few minutes ago. Fluid electrolyte abnormalities, developed ascites, right? Cardiovascular, if it is untreated, lead to the cardiac dysrhythmia and development of collateral circulation or portal hypertension. Hematological findings, if liver does not work, liver does not produce so many factors that is very essential for the blood, and patient develop anemia or disseminated intravascular coagulation or impaired coagulation, right, or thrombocytopenia. All of this is important for sign symptom of the cirrhosis of the liver. In this picture, showing some major data or sign symptom, I want to recap one more time. So I said the jaundice is most common, yellow discoloration, spider angioma. So in the body, the special type of blood mark or engorgement, if the men, they develop gynecomastia. So chest look like breast, right? And pancreas or liver increase the size, and it's called hepatomegaly. And also, I said most common, ascites or plumbar erythema, the red spot here, and also clubbing develop. So here some example, signs symptom of neurological findings: pulmonary like dyspnea, hydrothorax means water accumulate, very late stage, hypoxemia. What are the other gastrointestinal disorder developed, like abdominal pain? Patient develop anorexia, means decrease the appetite. Also clay color stool, because bilirubin present in the stool. Diarrhea, esophageal varices, gallstone, gastritis, hepatomegaly, right? So if my patient have a cirrhosis, what are the intervention, right? It is important for my NCLEX board. So elevated the head of the bed to minimize the shortness of breath. So if you see your patient has a shortness of breath, definitely it is good to semi-polar posture, right? Or elevated the head of the bed. Give them high protein diet, because patient develop liver problem or ascites. High protein is recommended. Vitamin supplement, especially they said B complex, vitamin A, C, and K, folic acid or thiamine. Folic acid, deficiency of folic acid develop anemia. Thiamine, deficiency of thiamine or B1, patient developed beriberi. Restrict sodium intake. Not only the cirrhosis, if patient have a renal disease, restricted sodium intake. If patient have a hypertension, restricted sodium intake. If patient has a Meniere's disease, also give them restricted sodium intake. So also admin diuretics is prescribed, right, to treat ascites. So diuretics basically help to reduce the edema. What else? So monitor the input and output and electrolyte balance. So usually the input and output should be equal. Electrolyte imbalance is most common if patient develop the cirrhosis. So we have to check the electrolyte balance, because electrolyte imbalance lead to arrhythmia, and arrhythmia lead to heart failure and patient die. Also, we has to measure their body weight or measure the abdominal gait to see the ascites increase or not. Monitor the level of consciousness. Why? Because anemia, and anemia lead to hepatic encephalopathy, right? So monitor for the fetus hepaticus, what it is. So if the patient have the liver problem, if we go close to them, we can get fruity, musty breath odor of severe chronic liver disease. So if you get this special fruity odor in their smell, you can understand the patient maybe have a liver problem. In this picture showing how we measure the abdominal gait. Marking on the abdomen through the measurable tape, and definitely we make the measure at the largest diameter. What next? So assess the administered blood product as prescribed. Blood product, right? Monitor the coagulation laboratory studies. Vitamin K may need to prescribe vitamin K because K does not synthesis. Give them antacid and also lactulose. This is the question NCLEX board like to ask. If patient has a hepatocellular carcinoma, if patient have a cirrhosis, what you have to give? Lactulose. Why? Because lactulose help to absorb ammonia, right? So admin the lactulose as prescribed, which decrease the pH of the bowel and decrease production of ammonia, right? Unless ammonia accumulate in the brain and impair the brain function. Admin antibiotics as prescribed and avoid the medications such as opioid or sedative, barbiturate. All medication metabolized in the liver. If the liver doesn't work, who will metabolize your medication and excrete out through the kidney? Kidney can work because everything is processed by the liver. If liver does not work, right, it would be accumulate. So better if the patient have a kidney problem, do not give opioid or sedatives or barbiturate. What next? Reinforce the instruction about the importance of abstinence of alcohol intake. So if your patient have this problem, definitely alcohol is restricted, right? And prepare your client for paracentesis. What it is? It is make it easy. Paracentesis is a process to remove the abdominal fluid, right? NCLEX board like this question, paracentesis. So paracentesis basically insertion a needle through the abdominal wall to remove the fluid from peritoneal cavity. So you see in this picture a man who fluid is accumulated in the abdomen and abdomen is distended, right? So if I ask you, what are the indication of paracentesis? Answer is ascites, right? Especially it is important, you have to stress it out. If the patient has ascites with respiratory distress, we indicate go for paracentesis. But because of our profession, you have to know what are the nursing care if patient go for paracentesis. So have the patient, when you dealing with the patient, you have to go for have the patient sign consent form before the procedure start, and also make sure your patient is void before the procedure, and also take the vital sign, measure the body weight, measure abdominal gait, or monitor for hypovolemia, right? and also admin albumin as prescribed. It is very basic information about the paracentesis. It can help to answer the question in NCLEX board. The next one here is called esophageal varices. So esophageal varices, what it is dilated tortuosity of the pain in the submucosa of the esophagus. So this is the esophagus, and the artery or blood vessel in the esophagus, they are tortuosity, right? So in this picture, this is the liver, this is the esophagus, continue with the stomach, and blood vessel is there, esophageal blood varices. So just have a look on the picture here, showing the swollen or fragile blood vessel, right? Swollen and fragile vessel in esophagus that can cause hemorrhoids. So the risk factor is a portal hypertension. So caused by portal hypertension, there is a risk factor. Bleeding varices are the emergencies because it is the life-threatening. The goal of the treatment is to control the bleeding, prevent the complication, and prevent the recurrence of bleeding. So here we go and we can see what next about the esophageal varices here. Next, here in this picture, showing again esophagus, liver, blood vessel. What are the sign and symptom or data? Hematemesis, right? What is hematemesis? What is melena? Hematemesis means vomiting mixed with blood. Melena means stool or poo mixed with blood. And you know what is ascites, jaundice. Spleen increase the size of the spleen size, increase the size of the liver. So liver increase, spleen increase is called splenomegaly or hepatomegaly. Sometimes the patient both are increased and it's called hepatosplenomegaly. Dilated abdominal vein, sign of shock, very late stage because of hemorrhage, rupture of restrained hemorrhage of esophageal varices are the primary concern because it presents a life-threatening situation. So if you go and check for liver enzyme, we can see elevated the liver enzyme, especially ALT or AST. And also bleeding is most common, so patient develop hypotension. Bleeding or hemorrhage or hypotension lead to shock. If patient have the shock, they developed tachycardia or palpitation, decreased blood pressure, decreased hematocrit and hemoglobin. So what are the intervention? What you has to do for them, right? So monitor vital sign, elevate the head of the bed. I said polar posture, monitor the orthostatic hypotension, means patient develop hypotension because of change their posture. Assist to monitor the lung sound, admit the oxygen as prescribed, monitor the level of consciousness, shortly called LOS, monitor the NPO, nothing by mouth, monitor the hemoglobin and hematocrit. And as I told you, if patient hemoglobin go down, hematocrit also go down, right? Assist to admit the blood transfusion, nasogastric tube. So if your patient is so bad, definitely we give them to take the nasogastric tube, right? So one of the indication of nasogastric tube are esophageal varices or intestinal obstruction, right? So if intestinal obstruction is the most, if the patient develop the intestinal obstruction, we have to start nasogastric tube. Definitely, if patient have the nasogastric tube, we have to care of the patient. Like we have to assess the bowel sound, abdominal gait, monitor the nasogastric tube for displacement, or assess the nasal mucosa for breakdown, right? Also, we have to monitor the input, output, monitor the electrolyte or encouraging ambulation to increase the peristalsis. So all are related or complete services to your patient when you go for intervention or care of them. So reinforce the instruction to avoid the activity that will initiate the vasovagal response. Prepare the client for endoscopic procedure or surgical procedure. Sometimes we give the patient propranolol. It is medical treatment. Propranolol. Propranolol means non-selective beta blocker or vasoconstrictor like vasopressin we give to patient. Endoscopic injection can help. The procedure involves the injection of sclerosing agents. Complication include chest pain, pleural effusion, or aspiration pneumonia, right? Or perforation of esophagus. So endoscopic varicose ligation is another procedure for stop the bleeding. So keep in mind the sclerotherapy or varicose band ligation, the procedure called, right? Or sometimes it's called transjugular shunt or esophagogastric balloon tamponel. So in this picture, endoscopic sclerotherapy showing this is the procedure for treatment of esophageal varices, sclerotherapy. So you see, this is the endoscopic and this is a bleeding blood vessel. So sclerotherapy can stop it. So they ligate the artery or varicose band ligation, or I said transjugular shunting, or sometimes we use esophagogastric balloon therapy. So the terminology I'm telling you, eso means esophagus, this area. Esophagogastric means gastric area, right? So same picture, different way doing. This is a banded varices. So here, varicose band ligation, right? Suturing. ligation system, but it is endoscopic. Another procedure is called shunting procedure. Shunt the blood away from esophageal varices. So portal-caval shunt involves anastomosis of the portal vein to inferior vena cava. Right? So transjugular shunt or balloon tamponel are the compress the blood vessel in esophagus and stomach by bypass. So here the picture showing the bypass surgery. Surgical shunting divert the portal venous blood from the liver to decrease the portal and esophageal pressure. So this is the liver and this one the portal vein, right? So we do and cut and ligate it, and it's called bypass surgery. Bypass for esophageal varices. So compression the blood vessel in the esophagus and stomach. Shunting procedure is called transjugular intrahepatic portal system. Transjugular means the approach through the jugular vein, intrahepatic, inside the liver tissue. And in the liver system, the blood vessels called portal system, and this is shunting, means bypass. Now go for another one is called very basic information about the hepatitis. So here we go the different kind of hepatitis. It is not so hard. So hepatitis, right, is the inflammation of the liver. So hepatitis mean the inflammation of the liver cell, right? What are the cause of hepatitis? Sometimes genetic disease or some medication including over the counter, alcohol, or hepatitis defined viruses like A, B, C, D, and E. So here the inflammation of the liver, right, by the virus or bacteria or exposed to medication or any hepatotoxic substance. The goal of the treatment including the resting the inflamed liver to reduce metabolic demand and also increasing the blood supply, thus promote the cellular regeneration and prevention the complication. The hepatitis basically, all type of hepatitis have some common sign and symptom, the disease. Common, I said. Here we say the type of viral hepatitis including A, B, C, D, and E, right? Hepatitis A basically transmitted through fecal-oral. Hepatitis B and C transmitted through blood or body fluid, right? B and C almost same way to transmit, or transmitted via IV drug use or blood transfusion as well. Hepatitis D or hepatitis G usually transmitted via the blood or blood product like hepatitis B. Hepatitis E transmitted by fecally contaminated water in underdeveloped area. But it is important, the common risk factor is IBDA, means IV drug user, hemodialysis, transfusion, even healthcare worker under the risk to contaminated this problem. In this picture showing the liver, this is the healthy liver. But healthy liver when inflamed is called hepatitis. So hepatitis lead to cirrhosis, and cirrhosis lead to hepatocellular carcinoma. Hepatocellular carcinoma. So if the patient have hepatitis, the patient usually present very beginning like flu-like symptom or fever or jaundice, even dark color urine or clay color stool. Dark color urine or stray color stool because of bilirubin present in stool or bilirubin present in urine. So when we go and check the laboratory test, lab test, we can see that increase the bilirubin level, increase the liver enzyme like ALT or AST, and bilirubin increase. The hepatitis A, when we collect the data, we can see in this picture the jaundice and liver should be palpable. There are three stages of the disease. It's called pre-icteric stage, icteric stage, and post-icteric. Means before jaundice, jaundice, and post-jaundice. The pre-jaundice or icteric stage, we can see patient have jaundice, flu-like symptom like nausea, vomiting, diarrhea, malaise, headache, polyarthritis means multiple joint pain. Elevate the serum bilirubin and enzyme means liver enzyme, ALT or AST. What about the jaundice phase or icteric stage? The second stage of hepatitis, icteric, include the appearance of jaundice, associated symptoms such as elevated bilirubin level, dark or color urine, clay color stool. Patient present with pruritus because bilirubin accumulate in the skin. Or post-jaundice stage or phase, it is called convalescence stage, in which the jaundice decrease and color of the urine or stool return to normal, and patient feel little bit energetics pain subside, and there is a normal to absent gastrointestinal system or bilirubin and enzyme level return to normal. So patient is almost be cured. Especially there's some basic information about the hepatitis A, right? So formerly, everybody known this is infectious hepatitis, commonly seen during the fall and early winter. Individual at risk who are the risk, crowded condition like nursing home, daycare, and exposure to poor sanitation because they transmitted by fecal-oral route, person to person or parental. What is parental, right? And if I say what are the parental nutrition, right? So contaminated food, fruits, vegetables, contaminated water, milk. So this is the way to transmit the hepatitis A. So incubation period for hepatitis A, incubation period means the take time to produce the sign and symptom of the disease. Hepatitis A, the incubation, I said transmitted by fecal-oral route, and incubation period is 10 to 50 days or 2 to 6 weeks. What are the testing we have to check the hepatitis A? Infected is established by presence of HAV antibodies or anti-hepatitis A virus antibody. Definitely, you know there are vaccination is available for hepatitis A. So infection is established by the presence of antibody. What antibody? Hepatitis A virus antibody. Immunoglobulin called immunoglobulin M or immunoglobulin G are normally present in the blood and increase the level of indicate infection and inflammation. So what next? If the patient is untreated, what are the complications arise? Complications called fulminant hepatitis. If the patient are acute or often fatal, is called fulminant liver or hepatitis. So question come, how we have to prevent hepatitis or hepatitis A. So strictly hand washing is the most important, and stool and needle precursor treatment of municipal water supply or serological scanning of food handlers. Definitely there are vaccine like hepatitis B, hepatitis A have a vaccination and vaccine is available. So strictly hand wash or frequently hand wash are the key to prevent the spread of all kind of hepatitis, right? Strictly hand washing is the way of prevention. And sometimes pre-exposure prophylaxis with immune globulin. And I said available vaccine are available to prevent it. Hepatitis B. Hepatitis B transmitted via blood and body fluid. And this is the first immunization at the birth. Definitely, if patient need to give them hepatitis B vaccine, check for yeast allergy or any allergy to this particular vaccine before administration. So hepatitis B is a non-seasonal or all age group can be affected. Who are under the risk? IP drug user or the client undergoing the long-term hemodialysis. Hemodialysis, transfusion, IP drug abuser, all, even healthcare professional. How this hepatitis B can possible to transmit it? By blood or blood product, infected saliva or semen, contaminated needle, unprotected sex, parental route, or perinatal. So during the delivery also can possible to transmit, right? Or blood and body fluid contact at the birth. Incubation period usually 6 to 24 weeks. What are the testing? Infection is established by presence of hepatitis B antigen, is called hepatitis B antigen antibody systems in the blood. So presence of hepatitis B surface antigen is the serological marker established the diagnosis of hepatitis B. So I want to recap it. Hepatitis B surface antigen, shortly called HBsAg. If it is present, we say the patient has hepatitis B. And also, if the serological marker is present after 6 months, it indicates a carrier stage or chronic hepatitis. So what are the complications? In this picture again, chronic inflammation of the liver lead to cirrhosis. Cirrhosis lead to hepatocellular carcinoma. If hepatitis B is untreated or maltreated, lead to fulminant liver, chronic liver disease. What are the chronic liver disease? Cirrhotic liver or hepatocellular carcinoma. How we have to prevent? Frequently restricted hand washing, or before to blood transfusion, we have to scan it, testing all pregnant women, and also follow the precursor. So avoiding intimate sexual contact if the test for hepatitis B surface antigen is positive. Hepatitis B vaccine like hepatitis E, right? Now go for hepatitis C. Hepatitis C transmitted via IV drug use or blood transfusion, right? This infection can occur any age group. Infection with hepatitis C virus are common among the drug abuser and also major cause of post-transfusion hepatitis. Post-transfusion. Risk factors similar of those of hepatitis B, right? So the risk factor are IV drug abuser, hemodialysis, blood transfusion, or we who are provide the health care. So healthcare worker or provider as well, right? So they said who are individuals at the risk: parental drug user, client receiving frequent transfusion like sickle cell anemia, thalassemia, right? They need transfusion, or healthcare personnel. So complication of the incubation period is 5 to 10 weeks, and testing is an antibody for hepatitis B virus. So anti-hepatitis C virus is antibody to hepatitis C virus. So they lead to chronic liver disease. Chronic liver disease means cirrhosis and hepatocellular carcinoma. How to prevent? Like the others, hand wash, precursor during using of needle, or test the blood before transfusion. Hepatitis D. Hepatitis D and hepatitis G transmitted like hepatitis B, and hepatitis B transmitted via blood and body fluid. So hepatitis D is the common in Mediterranean area or Middle East area. Hepatitis D occur with hepatitis B, may cause infection only in the presence of active hepatitis B infection. So who have hepatitis B, then hepatitis C easily gets spread up. Co-infection with the delta agents like hepatitis D virus. Transmission and risk factor are same as hepatitis B, what I mentioned few minutes ago. What are the risk factor? I mean, IV drug user, client receiving hemodialysis, or client receiving blood transfusion, or healthcare provider. Incubation period 7 to 8 weeks. What are the testing? Serological means antibody again to hepatitis D virus. So hepatitis D antigen early in the course of the infection, and by detect of anti-hepatitis D virus antibody in the later disease states. What are the complications? If hepatitis D untreated, they lead to chronic liver disease or fulminant hepatitis. How to prevent? We can prevent it by because hepatitis D must coexist with hepatitis B. So if we prevent the hepatitis B, so you can prevent hepatitis D. So precautions that help to prevent hepatitis B are also useful to preventing delta hepatitis, D for delta. The other one is hepatitis E. Hepatitis E transmitted by fecally contaminated water. So it is called waterborne virus. So contaminated water in underdeveloped area. The risk of infection is the same as hepatitis E, and hepatitis A transmitted via fecal or oral route. Definitely good hand washing is way to prevent hepatitis E. So transmission is same hepatitis A, incubation 2 to 9 weeks. And what are the testing? Specific serological test for hepatitis E virus include detect of immunoglobulin M and immunoglobulin G antibody to hepatitis E, or antibody to anti-hepatitis E virus. So what are the complications? High mortality rate in pregnant because of hepatitis E. Prevention, strict hand wash or good hand washing, right? Or contact precaution, right? Or treatment of the water supply. If same area, so many people is affected, or sanitation improvement. I left a table here and compare and contrast of different hepatitis. So if you go through, I believe it can help. So like example, hepatitis A, B, C, D, and E. What type of the virus they are? Like hepatitis B and DNA virus, whereas the rest of all are RNA. DNA are the double strand DNA, and this is the RNA virus. Way of transmission. So hepatitis A and E, fecal-oral route, but hepatitis B, C or D, blood and blood product. So vaccination, like hepatitis E and hepatitis B have a vaccine, but hepatitis C and hepatitis D, there are no vaccination. So when you study compare and contrast, it will be easier to memorize. So if your patient have the hepatitis, how we have to dealing with them, right? Or as a RN or as a LPN, how we have to deal with the patient who have the hepatitis. So when we give the service, hand washing must be strictly maintained, or frequent hand washing can help to prevent hepatitis. And do not share the bathroom unless the client strictly adhere to personal hygiene measures, or individual washcloth, towel, drinking, eating, everything they has to use for themselves. The client should avoid alcohol or over-the-counter medication. The client should increase activity gradually to prevent the fatigue. And also tell your patient consume small, frequent meal and consist high carbohydrate and low fat food. So if it is low fat, liver has to take rest, right? So client is not to donate blood. So if anybody have this problem, discourage them to donate blood. They're not allowed. The client may maintain the normal contact with the person as long as proper personal hygiene is maintained. So close personal contact such as kissing or sexual activity should be discouraged who have the hepatitis B positive. The client need to carry the Medi-Alert bracelet. The client need to inform the other health professional such as medical or dental personnel, right? It is better to inform. The client need to keep the follow-up appointment with healthcare provider. So what next? Next here are pancreatitis, right? So we are going to talk about the pancreatitis. So pancreatitis here are pancreatitis basically acute or chronic, means acute pancreatitis or chronic pancreatitis, right? So it is the inflammation of the pancreas. You can see the picture. This is the gallbladder, esophagus, stomach, the second part of duodenum. In the second part of duodenum, the pancreas, it is the pancreas, and this is called pancreatic duct. Pancreatic duct met with the common hepatic duct, and they are open to the second part of duodenum, is called duct of Oddi, right? So if the pancreas is inflamed, it is called pancreatitis. So pancreatitis is autodigestion of the pancreas by pancreatic digestive enzyme that are prematurely activated before reaching the intestine. So I said that two types of pancreatitis. One is acute, but if acute pancreatitis is repeatedly attacked, or if the condition is more than 6 months, this is called inflamed, and inflamed is chronic. The risk factor like biliary tract disease. So like this is the gallbladder. If the stone in the gallbladder and the biliary system sclerosis, the chance to develop pancreatitis. If anybody has a biliary disease, alcohol abuse, GI surgery, trauma, or medication toxicity can cause pancreatitis. Let me read this definition first. Acute pancreatitis occurs suddenly as one attacked or can be recurrent with resolution. Chronic is a continuous inflamed or destruction of the pancreas with a scar tissue replacing the pancreatic tissues. So here, what are the signs and symptoms of the pancreatitis? Sign symptom. So the patient who have the pancreatitis, we can see they complain severe abdominal pain, and pain is left upper quadrant basically, or epigastric area that radiate to the back or left shoulder. Sometimes patient present with nausea and vomiting. So abdominal distension, gardening, weight loss, absence or decrease the bowel sound, elevated white blood cell count, elevated serum, lipase or amylase. It does not necessarily all the time. Every patient have to have all of the sign and symptom to diagnose the disease. But who have the pancreatitis, it is common to get to sign, and this is called Collins sign and Turner sign, right? Collins sign, basically the blue or gray discoloration around the umbilicus. So this is the umbilicus. So this is the blue discoloration or gray. Or Turner sign, basically the ecchymosis. This is the ecchymosis in the front area, right? And patient also present with jaundice or ascites, or very late stage present with tetany. So if we go for laboratory test, we can get the or increase the amylase or lipases, WBC increase or bilirubin level increase or glucose level increase as well, because pancreas secrete insulin and insulin digest the glucose. But if you check the calcium and magnesium or platelet, they are decreased. So what are the intervention if your patient have pancreatitis? Intervention or nursing care, right? So better to tell patient nothing by mouth if they are acute exacerbation, or NG tube here, NG tube, we has to give them antiemetics or insulin or IV fluid and electrolyte, and also give them opioid analgesia. So you see, opioid analgesia. Because of pain, right? Because of pain, we give them opioid. So sometimes patient need pancreatic enzyme. Sometimes patient need the pancreatic enzyme for what? So especially pancreatic lipase, because pancreas does not secrete pancreatic enzyme. So if you give them some meal or snack, also we give them pancreatic enzyme. So now go here, how you have to educate them in reinforce the instruction to the importance of avoiding alcohol. So no alcohol consumption, no smoking, and reduce the stress, right? Reinforce the instruction to notify healthcare provider if acute abdominal pain, jaundice, clay color stool, or dark urine. If the patient have a chronic, the sign symptom, abdominal pain, tenderness, left upper quadrant pain, steatorrhea means stool mixed with fat and foul smelling stool, weight loss, muscle wasting, and jaundice. Usually the chronic pancreatitis patient develop that in diabetic because of impaired secretion of insulin by the pancreas. So intervention, it is similar to the chronic pancreatitis, right? Let me read it first. Client is instructed to the pancreatic dietary measurement and also avoid heavy meal, avoid alcohol, give them supplement of vitamin, give them pancreatic enzyme, also admin insulin, right? Also here, reinforce the instruction to the client on treatment plan for glucose, instruct to notify healthcare provider if they have a steatorrhea, or enforce the instruct is the importance of follow-up visit, right? So if the patient have pancreatitis, we tell them keep them nothing by mouth or NG tube feeding, antiemetics, insulin, IV fluid and electrolyte, or opioid for pain. No alcohol, encouraging alcohol totally stop, or no smoking and reduce the stress. Usually the chronic pancreatitis has some complication. So acute pancreatitis, if untreated, lead to the chronic pancreatitis, right? Also, acute or chronic chance of develop the pancreatic pseudocyst or chance of develop type 1 diabetes. So all are the complication of pancreatitis. The next disease we should talk about the irritable bowel syndrome. What it is? So IBS, shortly called IBS, an intestinal disorder causing the abdominal pain or gas, diarrhea, and constipation. So the patient who have the IBS, usually patient come with either abdominal pain or gas formation or diarrhea or constipation. Some patient present IBS with only constipation, some patient present with diarrhea, right? The underlying cause of IBS is unclear, but may be influenced by the environment under the stress, hormonal or genetic. So what are the intervention and what are the patient teaching? So if anybody have the IBS, tell them to increase the dietary fiber or drink 8 to 10 cups of liquid per day, right? So we has to educate the patient to avoid the dietary or avoid the eggs or wheat product, avoid the alcohol, avoid caffeine. Better to tell them to increase the fiber containing food or fluid intake at least 2 to 3 liters per day, and keep the dietary of food intake and bowel pattern. What the medication therapy? What are the medication therapy? It is depends on predominantly symptom. It is depends on the symptom, right? So here I said the medication name is lubiprostone, Lubiprostone, right? This is the medication for IBS with constipation. But if your patient have a diarrhea, that times you have to choose different medication, right? So this is the constipation predominantly. But if you have a diarrhea, we have to choose allosterone, allosterone, allosterone for IBS with diarrhea, right? With diarrhea. But keep in mind, if you give them allosterone, the side effect constipation. If you give them lubiprostone, the side effect is the diarrhea. So next here, ulcerative colitis. very important, ulcerative colitis or Crohn disease. Even we will talk about the intestinal obstruction, we'll talk about inflammatory bowel disease and also diverticulitis, right? It is important we has to know the ulcerative colitis, Crohn disease or diverticulitis all are together called inflammatory bowel disease. Inflammatory bowel disease, right? So the first one is here ulcerative colitis. So ulcerative colitis are the inflammation and ulceratives, inflammation disease in the bowel or inflammation of the colon and causes the continuous lesion or lesion. So symptoms are you who have this, they come with the left lower quadrant pain or fever. Also patient present with 15 to 20 times liquid stool per day. So if anybody go to the toilet for 20 times stool, definitely it is disturbing. Not only disturbing, they lose the fluid, electrolyte imbalance, right? Let me read it first. Commonly begin in the rectum and spread upward towards the cecum. The colon become edematous and develop the bleeding or ulcer. The scar tissue developed and causes loss of elasticity and loss the ability to absorb the nutrient. The colitis is characterized by various periods of remission or exacerbation. Acute ulcerative colitis result in vascular congestion, hemorrhoids, edema, or ulceration of the bowel mucosa. Chronic ulcerative colitis causes muscular hypertrophy. So in this picture, we can see the stomach, then this is the small gut, jejunum, ascending colon, transverse colon, descending colon. So ulcerative colitis, we say the inflammation of the colon, especially where, if we go back, ulcerative result in the, you see, rectum, start in the rectum, so this area, but they gradually go up. So ulcerative colitis patients sometimes present with anorexia, means decrease the appetite, or weight loss. If you do not eat, weight loss is normal. If you go so many times for the stool, 20 times liquid stool per day, definitely weight loss. Malaise, abdominal pain, severe diarrhea that may contain blood or mucus. All of these conditions lead to malnutrition, dehydration, electrolyte imbalance, anemia, and vitamin K deficiency. So the person who have ulcerative colitis, if you go for endoscopy, we see the picture, you can see very mild, is almost normal, but here it is narrowing, and this is the ulcerated. So if your patient have the ulcerative colitis, what we have to do? So keep in mind ulcerative colitis or Crohn disease, the teaching or laboratory study is almost same. Okay, so here let me go through first here. So in case of acute phase, so maintain the nothing by mouth. So if at the beginning acute exacerbation of chronic ulcerative colitis, we have to keep them nothing by mouth, IV or admin the fluid and electrolyte via IV line or parenteral nutrition. Restrict the client activities to reduce the intestinal activities. Monitor the bowel sound or monitor the stool, color, consistency. Monitor for the bowel perforation, because bowel perforation leads to intestinal obstruction, another problem, right? So if the patient is having intestinal obstruction, we have to find it out by the clinical symptom. Usually patient present with abdomen distension or obstipation, abdominal pain, or hypoactive bowel sound. Anyway, this is the complication. So what next? We have to give them high protein diet with vitamin, right? Also tell your patient to avoid gas forming food, right? What are the food list? They produce the gas, like milk and milk product, or wheat, grain, nut, raw fruits and vegetables, peppers, alcohol, or caffeine. So you must tell your patient to avoid the smoking. So this is the food list they should avoid. You can see the picture, right? And also another side, the food you has to encourage your patient who have ulcerative colitis. So I said the not only the medicine or medication, the care, nursing care or education is super important for your patient, right? So if the patient is really bad, we have to go for surgical management, and this is called perform the extreme cases surgical intervention. So minimal invasive procedure are considered as a surgical option if the client is a candidate or client who are obese. Minimal invasive means instrumental intervention in the treatment procedure. So another surgical intervention is called retroactive colonectomy with ileal pouch anal anastomosis. Is a surgical procedure. So what next? We just touch a little bit the name, because definitely you do not get any question for NCLEX board. So what are the surgical options? But you have to know the surgical option, one of the options for the treatment for ulcerative colitis, right? So before the surgical option, we have to check the laboratory test, lab test. So during the lab test, we have to get decreased hematocrit or hemoglobin or albumin. but increase the ESR. ESR stands for erythrocyte sedimentation rate, or CRP, or WBC increase, right? The ulcerative colitis or Crohn disease most common in Caucasian or Jewish descent, or the person who under the stress all the time, or autoimmune disorder. The medication basically we use for ulcerative colitis or Crohn disease are 5-aminosalicylic acid or sulfasalazine, or steroid. Example, corticosteroid like prednisolone, or immunosuppressant like cyclosporine, or antidiarrheal like loperamide. So after the surgery, what are the post-operative intervention? Here, consult with the enterostomal therapist. Reinforce instruction to eat a low-fiber diet, parenteral antibiotics, right? So here, the post-operative colostomy intervention. If anybody have it, we have to tell how to take care of colostomy bag. So post-operative, the pouch system with a skin barrier is usually placed on the stoma. So this is the stoma. We use a pouch up there, and we tell our patient how to take care of it, right? So we have to monitor the stomal size, color, unusual bleeding, or blackening. Blackening means necrosis. Monitor for the color change of the stroma. Note that the stroma, normal stroma color is the pink to bright and red and shiny, and it indicates high vascularities, right? But if we say the pale pink stoma indicate low hemoglobin, low hematocrit, and purple black indicate less blood supply, less oxygen, compromised circulation, and we have to notify to the healthcare provider. So post-operative colostomy intervention continuation. Expected that the stool is liquid in immediate post-operative period, but become more solid or depending on the area of colostomy or ascending colon. If the colostomy in the ascending colon, it would be liquid stool. If it is transverse colon, loose to semi-solid. If the colostomy is large, descending colon, it should be normal. We have to monitor the pouch. We have to monitor the fecal materials, monitor for dehydration and electrolyte balance. So a stroma that is purple black in color indicate the compromised the circulation. Means less blood supply, less oxygen supply, necrotic change. We have to inform healthcare provider. So what next? In case of ulcerative colitis, so purpose of this colostomy irrigation purpose is enema is given through the stoma to stimulate the bowel emptying, right? Irrigation is performed by instilling 500 to 1000 ml of lukewarm temp water. Very important. Now go for Crohn's disease. Another important information about this. The Crohn's disease is the inflammatory disease that can occur anywhere in gastrointestinal tract, but most often has affected the terminal ileum, right? And lead to thickening and scar formation, narrowing the lumen, or develop the fistula, ulcer, or abscess. So Crohn's disease, if I make it summary, this is the inflammation and ulceration of the small intestine that causes the sporadic lesion and risks to develop the fistula. So what are the signs and symptoms of Crohn's disease? What are the signs symptoms? Symptom: right lower quadrant pain or cramping, fever, usually patient 5 loose stool per day, but ulcerative colitis around 15 to 20 loose stool per day. Here is the 5 loose stool per day. And stool mixed with mucus or pus. Abdominal distension is very common, pain and diarrhea, right? Some people come with anorexia, nausea, and vomiting. What next? So inflammatory bowel disease. As the beginning, I told you the inflammatory bowel disease, ulcerative colitis or Crohn disease or diverticulitis all together are called Crohn's disease, right? So ulcerative colitis here in this picture, the inflammation of the terminal colon. Crohn disease are the inflammation and ulceration of the small intestine. And diverticulitis are the inflammation of the diverticula in the small pouch in colon as well. But all are inflammatory bowel disease. So what are the other signs symptoms of the Crohn disease? Like patient develop the weight loss, anemia, dehydration, electrolyte imbalance, malnutrition, right? What are the intervention? Care is similar to the client with ulcerative colitis, right? So if I said what are the care, what are the nursing care? Means monitor for the sign of peritonitis, like symptom of nausea, vomiting, or rigid or broad-like abdomen, rebound tenderness, fever, tachycardia. Monitor for import, output, electrolyte imbalance, or we have to give them some diet like patient keep them nothing by mouth during the acute exacerbation, or ongoing eat the food high in protein and calorie, but low in fiber. Avoid the caffeine, avoid the alcohol, eat the small frequent meal. So this is the intervention or caring of the patient who have the ulcerative colitis or Crohn disease. So another inflammatory bowel disease are diverticulitis, right? So what are the diverticulosis and what are the diverticulitis? So in this picture, you can see the colon, right? Ascending colon, then transverse colon, descending colon, and large sigmoid colon and rectum. So if in the picture number 2, you can see this is small extra pouch develop, and this is called diverticulosis. So sometimes food is get inside the diverticula or culosis and causes the inflammation, and that time is called diverticulitis. That time is called diverticulitis. So you can see this is the gut, but this is the extra diverticula formation, right? And this is called diverticulosis. Unfortunately, when food is passing by, some of the food go and get inside the diverticulosis and causes inflammatory change or inflammation. That times it is called diverticulosis, right? So here we go and see what next. So first of all, diverticulosis or diverticulitis, let me read it. Diverticulosis is an outpouching or herniation of intestinal mucosa. Herniation or outpouching. This is the outpouching. And diverticulitis is the inflammation of one or more diverticula that occur from penetration of the fecal matter through the thin wall diverticula and can result the local abscess, right? Food is go, not come back, or waste material is go or not come back, and they causes the inflammation. If long term stay there, chance of perforation or intestinal obstruction. So here you can see the endoscopy showing so many hole or pathway like this. This it is actually outpouching. So data collection, patient present with elevated temperature or GI upset like nausea, vomiting, diarrhea, abdominal cramping pain. Especially the pain is left lower quadrant, right? But it is the difference between ulcerative colitis and Crohn disease, right? Crohn disease, the pain at the right lower quadrant. The ulcerative colitis pain at the left lower quadrant. And diverticulitis also left lower quadrant, right? Or patient develop palpable, tender rectal mass or blood in the stool, right? So what are the intervention? So if we get the laboratory test, you can see that decrease hematocrit, decrease hemoglobin, but increase WBC. So better take them bed rest, nothing by mouth, or introduce fiber containing diet, give them medication like antibiotics, example metronidazole, or analgesic or anticholinergic drugs to reduce the bowel spasm, right? So as a RN, what is our intervention? So our intervention is, I said, first of all, nothing by mouth or clear liquid diet during the acute exacerbation, right? Or low fiber diet in case of acute exacerbation. Or ongoing process, eat high fiber diet. It is very important. So if patient are acute exacerbation, we give them clear liquid diet or nothing by mouth, and then progress to low fiber diet. But if ongoing patient eat the high fiber diet, avoid the seed, nut, or popcorn, because this type of food go inside the outlet pouch. Or monitor for the sign of peritonitis, like if patient complain of nausea, vomiting, rigid or broad like abdomen, or rebound tenderness, fever or tachycardia, right? So let me go the second, another disease is called appendicitis. Very, I will finish it. Appendicitis. So this is the terminal portion of small gut where the small gut met with the large gut. In this portion has one of the organ is called vermiform appendix. It is the rudimentary organ. Fortunately or unfortunately, sometimes the food particles or instaps go inside the appendix, and if it is not come back, the food particles causes the inflammation of the appendix, and this is called inflamed appendix or appendicitis. So inflammation of the appendix is called appendicitis. Usually patient complain the pain in the umbilical area, especially McBurney's point. Abdominal pain that is the most intense in the McBurney's point, or rebound tenderness positive, abdominal muscle rigidity because of pain. Patient have a low-grade fever or elevate the white blood cell because of infection, inflammation, or patient come with anorexia, nausea, and vomiting. When patient come, they like to side lying or laying position with abdominal gardening, or leg is flexed because they feel good. So I told you the most tender area is McBurney's point, because the McBurney's point, or this is the area, this is the umbilicus, and here is called anterior superior iliac spine. Okay, this is the Middle 2/3 and lateral 1/3 portion is McBurney's point, where the base of the appendix, and this area is most tender because of appendicitis. In this point, picture showing the location of McBurney's point, right? So here we can see this is the umbilicus, and this is anterior superior iliac spine. Umbilicus, anterior superior iliac spine. So from this spine, it is 1/3 middle. From umbilicus, it is 2/3 lateral, and this is the meeting point we called McBurney's point. So the surgeon do the incision in that area to get the appendix. And the treatment of appendicitis are appendicectomy, means remove the appendix. So now go here. Sometime appendix causes the complication, and this is called peritonitis. So what is peritonitis? Inflammation of peritoneum. What is peritoneum? Peritoneum are the layer that is cover the peritoneal cavity. So this is the peritoneal cavity you can see in the picture, and this outer layer is called peritoneal coverage, and this is peritoneum. So if the inflammation in this peritoneal area, this is called peritonitis, right? The treatment of appendicitis is called appendicectomy, means surgically remove the appendix. So if a patient is go for appendicectomy, before the surgical remove, what you have to do or what you should do, right, is called pre-operative intervention. Before. Tell them nothing by mouth, assist to admin fluid to prevent dehydration, monitor for change the level of pain, monitor the sign of rupture appendix, or monitor for the sign of developed peritonitis. If patient develop peritonitis, it is not good time for surgical operation. Also position the client right side lying or low to semi-polar posture. Monitor the bowel sound. Apply the ice pack to the abdomen for 20 to 30 minutes every hour as prescribed. Assist the admin antibiotic as prescribed. Avoid the laxatives or enema. Avoid, right? Also, it is very important lab to know, avoid the application of heat to the abdomen of a client with appendicitis. After the surgically remove of appendix, what we has to do, right? After, monitor the temperature for sign of infection, monitor the incision for sign of infection such as redness, swelling, or pain. Monitor for nothing by mouth status. Advise the diet gradually as tolerate. If the rupture of the appendix occur, expect a drain to insert it. Also, maintain the patient position like low to semi-polar. continue postoperative. So change the dressing as prescribed, perform wound irrigation, or maintain the nasogastric suction, right? Or parental nutrition as prescribed, give them antibiotic or analgesic. The last topic for today, that is the hemorrhoid, right? So hemorrhoid, this one. So hemorrhoid means dilated varicose vein of the anus. So this is the anal canal, basically the terminal portion of the rectum. So in the terminal portion of the rectum, there are so many blood vessels, and blood vessels are very sensitive this area. So if this blood vessel are dilated or varicosity developed, is called varicose vein. So dilated varicose vein to the anal area is called hemorrhoid. There are two types of hemorrhoid. One is called internal, other is called external. Internal hemorrhoid basically above the anal sphincter and cannot see on inspection. So this area is called anal line or sphincter. If it is above towards the gut, is called internal. If the hemorrhoid is below the anal line and possible to see from the outside, this is the external hemorrhoid. Sometimes hemorrhoid is prolapsed. It's called prolapsed hemorrhoid. And prolapsed hemorrhoid can become thrombosed or inflamed. Hemorrhoid can causes by portal hypertension or staining or irritation, right? Or even constant constipation can lead to develop hemorrhoid. Constant cough, abdominal pressure towards the gut or rectum can develop the hemorrhoid. What next? Next here, so how to take care of them, or what are the data? Usually patient present with bright red bleeding during the defecation. So bright red bleeding indicate blood is coming from terminal part of last gut, right? Bright red blood. Rectal pain or rectal itching. So if the patient have the hemorrhoid, we tell them or encouraging take high fiber diet or and enough fluid. Promote them the bowel movement. Also tell them to take stool softener, right? Sometimes the local anesthesia can help to relieve the pain, but you have to tell your patient apply the cold pack to the anal or rectal area followed by seed bath. So you can see the picture. This is seed bath. It can help. Surgical intervention here. So many include the ultrasound or sclerotherapy, surgically remove or injectable sclerotherapy can help, or band ligation. Resection the hemorrhoid and ligation, this is called hemorrhoidectomy. After the hemorrhoidectomy, what are the take care of the patient? assist the client to a prone or side lying down position to prevent the bleeding, maintain the ice pack, or monitor the urinary retention, or reinforce the instruction to increase the fluid and high fiber fluid. And definitely seed bath can help. At least seed bath 3 to 4 times a day. Is on the bottom there are one YouTube link where is showing how to use the seed bath. If you have time, you can check these videos, and sometimes these videos can help to learn. Okay.